century, the psychoanalysts used to say that premature ejaculation is the cause of unconscious conflicts. And then later on, it was suggested that men with premature ejaculation are more sensitive in the genitourinary system, and that's why these unconscious conflicts are expressed this way with fast ejaculation. But later on in the 70s, Masters and Johnson suggested something totally different. They said that it's a result of learned behavior. So in other words, somebody who, when he was young, masturbated very fast because he didn't want to be caught masturbating, then he kind of learned to do it fast. Or somebody who would have sex with prostitutes very often and then he didn't have a lot of time, he kind of learned to do it very fast. So this is a theory that we still, in many cases, think it could occur in our patients. Kaplan later on said that what could be happening is that the man with premature ejaculation is not aware, he cannot perceive, he's not aware of the gradual escalation of the feelings and the sensations of wanting to ejaculate. So since a man cannot be aware of these stages of escalation, then he cannot control it either. So if we look at the literature and see, are there any personality factors that are associated with premature ejaculation? What do we have? So in other words, when we talk about personality factors, we talk about stable characteristics. These are also quite genetically predisposed, so we really can't really get rid of them if we have them. So the studies are not very clear because we have seen some very weak differences to norms and the PE participants. Men with premature ejaculation may be a little bit more compassionate or altruistic, in other words. Some other studies have shown that men with premature ejaculation have higher scores in trait anxiety. Trait anxiety is stable anxiety, okay? So they are more anxious than normal people. And in another study, men with premature ejaculation had higher scores in alexithymia. Do you know what alexithymia is? It's something that we often see in people that do not recognize their emotions. So it's people that it's very difficult for them to say how they feel. So if you ask them, how do you feel? They usually tell you what they think, but not what they feel. And then there are studies that show us if the way that men with premature ejaculation think, their thoughts are different to men without premature ejaculation. So cognitive factors. And what we see here is very interesting because these are the domains that we usually intervene on while we're doing therapy. So first of all, men with premature ejaculation are usually preoccupied with thoughts about controlling their ejaculation and thoughts about maintaining their erection and about whether they're able to satisfy their partner. This is all, of course, during the sexual activity. In the same study, it was less than 17% of the men that reported that they could focus on their own satisfaction. They were mostly concerned about the satisfaction of the partner. And in other studies, it has been seen that men with premature ejaculation are more likely to feel negative emotions when they're about to have some sort of sexual activity. So they might feel too nervous or guilty or embarrassed and so on. So it looks as if the fear of failure will cause higher anxiety, and this higher anxiety interferes with their sexual response, causing a sexual dysfunction, which will then reinforce higher levels of fear of failure. So they get into a vicious cycle that we then have to break during therapy. And what is the mechanism of anxiety? So how does anxiety cause premature ejaculation, or why is it associated with premature ejaculation? Number one, it could increase the sympathetic tone, which finally causes either erectile dysfunction or premature ejaculation. Number two, when a man feels anxious during his sexual activity, then he cannot focus on his own levels of arousal, so he cannot focus on his sensations that are escalating in order for him to control them. And another issue is that anxiety interferes with the learning process. In other words, imagine a young man who's having his first sexual experiences and he's experiencing premature ejaculation. This man will not be calm enough in order to learn how to control his ejaculation, because he will always be anxious that it's going to happen again. So he doesn't have the opportunity and the calmness to learn to control his ejaculation. Now, Roland says that there's a lot that we still don't know about this anxiety. So, for example, is it that, like, for example, men with PE, they're like genetically predisposed to feel anxiety or not? Or what kind of anxiety is it? Is it general anxiety that it is tied to their relationships with other people? Or is it anxiety that is just a consequence of them ejaculating too fast? Or is it just a fear of future poor sexual performance? We still don't really know. Another question is, are there any relationship factors that have been associated with premature ejaculation? Well, some studies have shown that men with PE experience less intimacy with the partners. Men with PE also feel less secure, and they also feel less experienced with respect to the sexuality of their partners, so they don't feel very competent in that way. And also, they seem to they report that their partner's orgasmic capacity through manual or through oral clitoral stimulation is lower than the partners of men without PE. So in other words, they feel that their partner cannot climax with oral or manual stimulation, and therefore they expect more from vaginal intercourse. Men's dissatisfaction and distress has been correlated strongly with the dissatisfaction and distress that they attributed to their partner. But on the other hand, men with premature ejaculation, they tend to overestimate their partner's dissatisfaction. So in other words, the partners report less dissatisfaction than one compared to what the men think they have. So the studies that I have shown you until now are studies that show that some factors are associated with premature ejaculation. Personality factors, cognitive and affective factors, and relationship factors. But obviously, this doesn't mean that it's a causation, okay? It doesn't mean that it's because of these factors that men ejaculate fast, but we know that they are associated. This is where we're standing today. So how can we use this in the clinical setting? How can we use these data? Number one, well, if we see that our patients have some certain personality characteristics, then maybe these could have a prognostic value. So in other words, if we see that we have a patient with very high trait anxiety, we could expect that this will be an obstacle in our treatment. Then we have to try and see his cognitions and his emotions before and during his sexual activity. So what comes into his mind? Usually we will see that they are very, very highly concerned about with their partner's satisfaction. And these are things that we can work with them to alter. We can also have a look at the relationship dynamics, especially a man that is constantly trying to satisfy the partner. This is the most classical one. We can also have a look if the problem has led the man to avoid intercourse but also avoid flirting. And don't forget, there are many men who are single that don't have a partner, so it makes their life much, much more difficult because then there's an obstacle in the relationship. And we need to always look for variance. I think this is important in all sexual dysfunctions. We need to look for variance. Is the clinical picture always the same? Are there cases where the symptom disappears? If there are cases that the symptom disappears, we need to try and understand if there are psychological factors that could explain this. If the symptoms are always the same and we see that there is no variance, we can then look at organic and psychological factors. But if there's variance, we can a look at psychological factors. So psychosexual therapy and premature ejaculation, what do we do? Can we do something? What could we expect? Well, okay, this is not Superman. I was told it's Flash. All right, so about the behavioral therapy, Juliana talked about this a little bit before. Basically, the classical behavioral therapy is exercises that the man is taught later. The partner can also take part in this. And what the man is taught is to be aware of his sensations that are escalating and learn when he's in about the 70% to control to control by minimizing the stimulation, okay, and staying on that stage. This is basically what the behavioral techniques do. First through masturbation techniques and then with the partner. Now, there have been some studies that have shown that the behavioral exercise can have some positive effects. You still need much more to be done there. And then we've got combination treatment. Combination is about pharmacotherapy combined with psychosexual therapy. So we have data that shows that combination treatment is more effective than pharmacotherapy alone, and you can see over here. So citalopram and sex therapy is superior to citalopram alone, and so on. Now here is a recent study that shows that compares men taking duloxetine only and men taking duloxetine and receiving psychosexual therapy together. Now, psychosexual therapy is not only the behavioral exercise that I told you before, but it also intervenes a little bit on the thoughts that we were talking about and the conditions and the emotions of the man. And what we see over here is that group A, which is duloxetine only, in 24 weeks, their IOT was 160 seconds, okay, that's 2.7 minutes. Group B, which was duloxetine with sex therapy, went to 6 minutes. So adding psychosexual therapy, brief interventions, working on the factors that I told you before, can actually make a big difference. So the central concept of psychosexual therapy is to teach the man to identify and then to respond to the bodily sensations that precede the emission stage. The behavioral exercises can be useful. Sensate focus is a different set of exercises where we help the couple gradually get together, and we help the couple feel gradually less anxiety during the sexual interaction. And in some cases we can combine sensate focus exercises to the behavioral exercises for premature ejaculation. We can always add and combine these with some cognitive interventions on the thoughts of the men. And of course, if there are couple issues, we can do some couple interventions. It depends on the needs. And the combination with pharmacotherapy is always an option. Of course, even when the problem is, we think the problem is psychological. So the therapeutic targets, we want to achieve better control on ejaculation. We want to achieve better emotional intimacy, better sexual satisfaction, and higher self-confidence. It's not only about time, it's about having happy patients. So we must not forget that good sex is more than just sexual function. Good sex is about pleasure, enjoyment, and satisfaction, as it is defined by our patients. Thank you.